Studies have indicated that approximately 20% of Medicare beneficiaries who have been hospitalized return to a hospital for a rehospitalization within 30 days. The estimated cost of that nationwide is approximately $26 billion a year, a huge amount of dollars, that some of which can be avoided. And finally, more recently, rehospitalizations have, the attention has intensified because since October 1st of 2012, hospitals that have high readmission rates for congestive heart failure, heart attacks, and pneumonia are being penalized in their Medicare reimbursement. So it's a huge problem. Fourteen QIOs were selected by CMS to do a special project from 2008 through 2011 to improve care transitions in a community within their state. Each QIO selected a community in consultation with the Colorado QIO, which serves as the National Resource Center for care transitions work.
The community that was chosen was the Lansing community, and the reason why Lansing was chosen, because it was a perfect study area, because the Medicare beneficiaries in those zip codes within the Lansing area sought care within the Lansing community. Also, Lansing was chosen because of our partnerships that we had with the various hospitals and other organizations, healthcare facilities within that community itself.
So the work that we started in Lansing in 2008 was multifaceted. One of the pieces of the work was really to pull together a broad collaborative of providers that was made up of different healthcare settings, and so hospitals, nursing homes, hospice, home health agencies, and multiple community partners to really come together to really discuss some of the challenges with care transitions from a community-based approach. So we pulled the group together to begin to have some crucial conversation about care transitions and what some of the drivers of care transitions were. Some of the discussions were about barriers to transitions. Some of the communications issues were always a challenge. Discussing challenges as it related to medication management, discharge instructions, patients being motivated to take care of themselves. So those were some of the things that we talked about. So one of the biggest initiatives in Lansing was developing the Heart Failure Passport, and it was actually a tool that patients could use to track all of the things that they needed to in order to manage their care at home. Some of the signs and symptoms of heart failure that would maybe need a physician phone call or possibly need a visit to the ED, things like that. And the goal of the tool was to provide it at the hospital setting when the patient first was admitted to the hospital, and that the hospital staff would use this tool to educate the patients and their caregivers about their disease process. As the patients were preparing for discharge, then they would actually then be asked to take that tool as they moved to the other healthcare setting. So if they went to skilled nursing, the tool would go along with them, and the staff at the nursing home would take over that educating of the patient. If they were being seen in the physician office, the tool would be taken with them, or the passport would be taken with them, and the physician could take a look at it and get a feeling for the patient's medications, their current weight, what was going on with them as they kind of progressed from setting to setting.
MPRO's work in Lansing, intense work in Lansing, and pulling together that community into a coalition resulted in a 4% reduction in rehospitalizations and a 4% reduction in admissions within the Lansing community. This reduction also had a significant cost savings. During the study period, that reduction resulted in a $3 million cost savings to Medicare.
More interestingly, that the work continued beyond the 2009-2010 study period. And when we look at the results through June 30th of 2012, By that time, there was actually a 7% reduction in hospitalizations for Medicare beneficiaries and nearly a 9% reduction in rehospitalizations for that population. Startling results that continue to this day. So the Lansing model that MPRO implemented with the coalition in Lansing has now ballooned into work that the QIO program and including MPRO are doing in our current 10th scope of work. And it is now spread to over 400 communities across the country, that very same model that brings together people in the community across the continuum to work on care transitions. In Michigan, MPRO is currently working with 5 communities as part of our 10th scope of work with a very similar model that looks at data analysis, bringing interventions to a community coalition, and doing the same kind of process that we did in the Lansing community that was part of that study. The JAMA study looked at the 14 selected communities that QIOs were working with and compared them to 50 other communities across the country that did not have active care transitions activities going on. They looked at the results comparing 2009 and 2010 to the period before the project began. What the JAMA study found in the 14 selected communities is that the rehospitalization rate for Medicare fee-for-service beneficiaries was reduced by approximately 5.7% across those communities. Interestingly, not only did the rehospitalization rate go down, but the hospitalization rate for Medicare fee-for-service beneficiaries also went down by approximately 5.7%. When compared to the 50 matched comparison communities, the hospitalization rate actually reduced by twice that of the comparison communities, and the rehospitalization rate was reduced by nearly 3 times those comparison communities. Significantly better results in the communities where QIOs were actively working with coalitions in those selected communities.
Well, the QIOs are a great fit for this work because of the fact that we work with healthcare facilities throughout the continuum of care. We work with community-based organizations. We don't work with one healthcare entity. We also are a neutral party, and we're a convener. We can pull together and convene communities to work on a quality issue.
So the benefit is that we keep them out of the hospital. The benefit is they stay safe. They aren't exposed to things that in the hospital that they shouldn't be, and that it's less taxing on them. It's less taxing on their family members.
This means a lot to the Medicare beneficiaries. They don't have to bounce back into the hospital. There's less confusion on what they need to do in order to self-manage their care. Also, increased communication and a seamless transition from one setting to another.
CMS has now funded, through the Community Care Transitions Program, a number of communities to do similar kind of care transitions work. In Michigan, 3 communities have been assisted in applying for those Community Care Transitions Program grants and have received them. A 4th community has received a grant, and MPRO is now providing technical data assistance to that community. And there's a 5th community that is awaiting word on their grant proposal. One of the communities that we have assisted to get that grant is the Lansing community. So the work that we did under our special project has now resulted in that same coalition working with the Area-Wide Agency on Aging, being able to take that work even further through the Community Care Transitions Program. ACOs will have a very strong incentive to find ways of keeping rehospitalizations down as much as possible through better care coordination, because they will be responsible for keeping the Medicare payments below their historical levels to achieve shared savings or not lose money on their accountable care organizations. The kind of work that we've been able to do with care transitions will easily translate into the kind of work that ACOs are going to need to do in order to be successful.
The efforts to reduce rehospitalizations is not going to go away. It's going to continue.
It's big. It's a huge impact. It's not, it is one patient at a time, but it's so much more than that.